distance.
Yes, now it should be correct. All right. A very good afternoon, everyone. Welcome to Ivy Talks April edition. I am Pooja Swarup Saxena on behalf of INS India and Polymed. I welcome you all to the April edition hosted by a very new chapters in INS India, Chhattisgarh chapter, supported by MP chapter. So, as you all know, Ivy Talks is an exclusive forum for INS India members. We have started it last year and we are getting a lot of love and appreciation from all of you for this on this platform. And week month by month, every month a new chapter is coming up, hosting the session and sharing lots and lots of experience and insights with everyone. Quickly, you can just please type in the chat box from where are you joining in, your city only in the chat box quickly, so that we know where and all we have reached so far today. We see around 116 people. Yes, it's already crossed 100 in a very starting, which is very good sign. Chandigarh, great. More. Indore, Goa, wow. And quickly, Ludhiana, very nice. Muzaffarpur, wow. Great. So as you all know that in Ivy Talks, there is a discussion followed by an open forum. So every month we bring in expertise from different fields who are very much relevant. The topics are very much relevant from the day-to-day practice perspective. And it is a platform where we discuss real-time case scenarios. You'll get solutions for your queries. So stay back for till the open forums time. We would be having all the chapter officials from the hosting chapters as well as the INS leadership in here. So some simple rules which the regular audience know for Ivy Talks. Whatever your queries are, questions are, you can tap in the chat box. So to get the instant replies, you want to discuss something, place it in the Q&A box. We would be having a detailed discussion with all the speakers towards the end of the session, which we call as the open forum, right? So with this, we would be starting the session for today. To start it, we would invite Madam Madhukari Ray. Ma'am is President INS India to flag off the session for today. Ma'am, over to you.
Thank you, Pooja, and good afternoon, everybody, the chapter officials and the attendees, today's attendees, those who have taken out your valuable time to attend this Ivy Talks. I would thank Pooja for taking this initiative of Ivy Talks every month from Polymed, because this really created last year lot of impact in the practices in the INS infusion therapy practices. And this year we have evolved with more and more practicality. We have come up with the topics which are more challenging so that we can get out of the queries of the confusions that we face every day at bedside. So our nurses can be benefited by attending these IV talks. That was the motive, because which really Polymed has taken care of. I must thank Dr. Atul and Pooja for taking this initiative for the nursing fraternity to learn in one platform. And I must congratulate the officials of Chhattisgarh, because it is a new chapter and the chapter is so active that they have come up with this Ivy Talks topic, which is so apt for today's, that we all know that how the lines are the life-saving for all the patients that we receive in the hospital. So on behalf of Colonel Binu and INS India US affiliate, Colonel Binu is our CEO who will be joining us shortly. On behalf of Colonel Binu and INS India, I welcome once again the chapter officials, which is headed by Chair Colonel Chobi Kanjilal. Welcome, Dr. Chobi, Colonel Chobi. We have chapter co-chair Ms. Shakuntala Kartam, and both of them don't need any introduction. We have the General Secretary for the chapter, who is Mr. Jeka Pradeep Kumar. Can we have your camera on, Jeka? Mr. Pradeep, so that everyone knows your face, who is the General Secretary of the chapter. Are you there in this? Can you put on your camera and show yourself? I can see Colonel Chabi here. I can see Shakuntala.
I think we can see him. You can unmute, Mr. Jacob. You can unmute yourself.
Yeah, please unmute yourself and say hi.
It may be some technical glitches
Some
there. He's there,
technical
ma'am. I can
glitches.
I can see him.
Okay,
Yes.
fine. So whenever you are coming out of the network issue, please say hi so that we know you. And then we have the chapter scientific manager, who is Dr. Shweta Patras. So, Dr. Shweta, are you here? Can we see you once? Dr. Shweta is here, who is the scientific manager for the chapter. And we also have Dr. Supriya Mandal, who is the iNews POC. Dr. Supriya, welcome to you once again in
Good
the
afternoon, ma'am.
as a chapter official. So you can put the yeah, you can show your, we are able to
Yes,
see
ma'am.
you.
Good afternoon.
Yes,
Good afternoon.
good afternoon. So the chapter officials, welcome to all of you and welcome all the members, those who are present here. As you know, INS in collaboration with Polymed, Polymed is our academic partner, and that's how we are into IV talks and many more learning sessions. And we would encourage the members, those who are INS members, and through this chapter, those who take up the membership, they get benefited by all means, not only by enhancing their knowledge, also by enhancing the skill. Because we want to do subsequently, this is our one platform, and then subsequently, I wish the chapters come up with lot of skillathons so that you can build in skills amongst nurses, which is very, very important. So I would request all of you, please take it up, have some skill stations for on the pertinent issues like the pick line care, your central line care, and many more such things, so that the nurses can be benefited out of this. Also, once you become the members, this is my message from INS India, is that each member is going to be benefited with multiple courses that are available, and all these information are there in the website. So once you open the website, you will be able to access all these courses which are available and which will be coming up in near future. And try to be part of the national conference which happens every year. So that's my message to all the members and all the forthcoming members, those who have not yet become member. Please take membership so that you can come to this bigger platform of infusion therapy. As you know that Infusion INS has also come up with mid standards, and this is the third edition of standards that we had released last year. And we will be doing the standard edition and modification as and when we get the information from US, and it is in collaboration with US standards, so that we can ensure that we are at par with the world class standard in terms of infusion therapy. And that is the reason we have come up with another, our industry partner 3M has come up with another excellence, that is infusion excellence, that is called Infuse. That is also a certification which can be taken up by any hospital, so that the auditors can go. We have auditors across the country, so the auditors can be assigned to the hospital to take up this audit, and the hospital can be Infuse certified. So these are the advantages we have. We have many more in the platform. Once you open the website, you will be able to see. So without much ado, I do want the IV talks today's topic, which is very, very vibrant topic. We can start with the topic as early as possible. Thank you once again for having this session done, and go ahead with this. I'm sure that it is going to become a very, very successful session today. Over to you, Pooja.
Thank you so much, ma'am. This chapter actually, this IB Talks actually is hosted jointly. This is not only CG, we also have MP officials over here. Miss Lini is there. Ma'am is representing the MP chapter. MP is comparatively new for INS India, so it is right now they are sharing it with the Chhattisgarh chapter.
That's very good. Thank you so much, Sini. Yeah.
And very soon we'll in next IB Talks next year IB Talks MP would be having their own independent session as well. So. Welcome, MP chapter members. And next, I would like to introduce, invite, not introduce. Dolly ma'am don't need any introduction. I would like to invite Dolly ma'am, West Bengal chapter chair, as well as our iNews editor in chief, to please share your views on the same and set the context for today.
Thank you. Thank you so much, Pooja. Pooja, my dear colleagues, my dear friends, Captain Madhukari, the President of INS, Colonel Bindu Sharma, ma'am, will be joining shortly. Ma'am is the CEO, as Captain Madhukari already said. Pooja, you are doing a wonderful job by commencing this IV talk every month and month. All the chapter officials, Shakuntala, I can see Chabi. So hats off to you that you people have taken up this. So, very aptly chosen topic as this lifelines. People, those who are working in the clinical setup, every now and then getting allocations with the lifeline. And, this is very important for a nurse to know where the line is in, the care of the line, how the line needs to be checked while taking handover. If there is any misses, then obviously our patient will land up with complications. Even a critical care nurse must have knowledge that whether can we start in one channel or of the central line are all kind of infusion, they should must have knowledge. So handling of the line, starting of the infusion, scrub the hub technique, aseptic non-touch technique, which continuously, INS is giving training, and this through the IV talk, the nurses are getting to know. And moreover, there are multiple options. There are many modules which are there online. People can get through and understand why these are important. Why Captain Madhukari has repeatedly said that get your membership through INS, because this is going to add to your credential that you are a member of Infusion Nurses Society of India. And if you take a membership, there are a lot of online modules which are there in INS website. You can access and you can get a certified nurse for giving an infusion therapy. You should know each and every aspects, the unique aspects while you are handling an infusion therapy, how to handle a peripherally inserted IV cannula, why we are emphasizing that one nurse, one cannula, and one prick success. Because nowadays the patient comes to our premises for the care, for the treatment, always say that, "Mujhe do bar prick kiya," because she or he doesn't know that within one prick the channel to be can be made. So you may need that type an expert hand. We can understand sometimes you face a difficult vein, or you may find that very elderly person torturous vein, difficult to get access and you miss. But if a patient is there with us, we have to always think about their safety, their security. If we can do in one prick a channel, then why should I go for two? So care of these lines are very, very important. When a patient with a central line, also you must know whether a central line only a three-way extension to be connected with it, or it will be always better if we use a a split septum device, a needle-free connector, because that will help us to to have the infusion with that line very safely. You just take a swab, alcohol swab, and you follow the scrub the hub technique and you infuse. And we have nowadays a chlorhexidine impregnated cap to take care of the line. So I am sure that the entire care of line will be discussed by this IV talk. All very eminent speakers are there, those who are going to conduct this session. And Pooja, thank you very much that you have taken all the efforts and giving to all the chapters to have this IV talk, so that many nurses today connected, many have joined in a group. I can see the photograph in a group. So they are going to get a thorough knowledge why it is important, and as a nurse, why we need to become an expert to handle all these lifelines. Thank you very much. So the session is open now, and welcome to all the speakers to have session by one by one. Thank you very much, Pooja.
Thank you so much, ma'am. And indeed, it's all set now. we would like to hand it over to the co-chair for CG chapter and our moderator for today, Shakuntala ma'am,
Yes.
all yours.
Good afternoon, everyone. I'm Shakuntala Kartam, Chief Nursing Officer at ITSA Hospital, Raipur, and it is my privilege to serve as a moderator for today's IV Talk session. As we move forward, today's themes when lines become lifelines, ensuring IV safety in critical care, remind us that every line we handle, it's not just a procedure, but a lifeline that demand precision, vigilance, and accountability. Over the next session, we are going to explore about infection prevention strategies, CLAPSI prevention bundle, practical IV therapy approaches, simulation-based skill enhancement. I encourage everyone to stay engaged, reflect on your practices, and note down the question for open forum. Now, it gives me an immense great pleasure to introduce our first speaker, Dr. Sava Javed ma'am, microbiologist and infection control officer at Ramakrishna Care Hospital, Raipur. She will be speaking on zero infection, zero compromise IV care that protects, a topic that is central to patient safety and quality care. Ma'am, we look forward to your valuable insight. Over to you, ma'am.
Thank you very much, Shakuntala. I would like to first thank the President of the INS, all the office bearers of the INS, Polymed, Shakuntala, President of the CG chapter, for inviting me on this valuable talks on this very important topic like care, IV line cares. And all of you know that already the madam already said, the Dolly madam, regarding the importance of the IV lines. These are the lifelines for the patient. So whatever I would like to share my thoughts on this, it will be a privilege for me. Please share. बड़ा कर सकते हो हाँ इससे So, I'm a Dr. Sabha Javed. I'm a Senior Consultant Microbiologist and Infection Prevention Control Officer at the Ramakrishna Care Hospital, Raipur. It is a tertiary care super specialty hospital at the Raipur, Chhattisgarh. So, basically, in my hospital, what I said that regarding we definitely care the most critical patients in our hospital. And all of you know that whenever a patient landed in the hospital, either through an emergency or directly admission into the ward, and most common thing or the process or the administration is the IV lines. And definitely these are the life-saving things. And a nurse can do this as a first procedure to the patient. So basically the intravenous therapy is a medical technique which delivers the IV fluids, the important antibiotics, the nutrients, the blood products directly into the patient's vein. So whether a patient are severely dehydrated or with a poisoning or with a severe infection. So these are the rapid way of the delivering the any fluid or the medication directly into the vein. So because it is 100% bioavailable absorption, which bypasses the GI tracts. But definitely because this is an invasive procedure and invasive process, so please आप बाहर जाओ. Because it is an invasive procedure, so definitely it needs a very skilled or technical training. Whoever administered this type of the therapy must be clinically trained, must know all the protocols. Because one side it is a life saving, but another side it has certain complications like the hepatitis, infiltration, discomfort. And if you are not taking the proper aseptic care, then patient may land up into the infection also. So if we say next, what is the, basically I am talking on the peripheral lines, and because the next speaker will talk on the central line also. So basically what is the related infection rate on the PIVC? That is, it is the incidence is, although it is low, like the 0.15% or 65 per lakh catheter days. And the catheter-associated blood stream infection rate is, it is also low, 0.028% or 4.4 per 1,000 catheter days as compared to the central line, which is very high. But it accompanies, whenever it happened, definitely it resulted into a significant mortality, especially in the critically ill or immunocompromised patients. The most common organisms which causes the infection are the Staphylococcus aureus and the our skin bacteria, that is the coagulase negative staphylococci. Next. So why the infection control is important while we are putting that central line, putting the peripheral line, or accessing the line, or we are maintaining the line, because if we will do all the precautions, all the protocols in care, then we can prevent the infection, and that will ensure the patient safety also. And if it is a poor infection control, definitely it will lead to the serious infections, may lead to the sepsis or the systemic infection. If we are in full control or in the full process of the infection control practices, during these putting the lines or accessing the lines, then we can reduce the CRBA size, we can reduce the hospital acquired infection. If we are doing the stringent hand hygiene during the line handling, then we can limit the spread of the microorganism. In this way, we can protect our the high-risk patients, vulnerable patients, elderly, neonates, immunocompromised patients, patients with the comorbidities. Next. Then in this way, reducing the HAIs or preventing the spread of the infection, we can prevent the prolonged hospital stay. In this way, we can reduce the treatment costs, the indiscriminate use of the antibiotics. This may indirectly affect the reducing the AMR also, and reduces the needle-stick injury. We can follow the needle-stick injury protocols, occupational exposure to the infections, and by maintaining the line, properly putting the line, we can prevent the local complications, phlebitis, abscesses, cellulitis, and in this way we can maintain a healthy IV insertion site. So what are the different key infection control measures? All of you will agree with me 100%. The number one is the hand hygiene. Definitely either we can wash with soap and water, or we can use the alcohol-based sanitizer. So always before and after touching the IV site or tubing, either inserting or accessing any line, when you are replacing the dressings or handling the connectors. So what are the key hand hygiene moments in IV care? These are very, very important, and every nurse must ensure this whenever they are accessing any of the system, either it is a connecting tubing, or whether you are injecting some medication, or you are taking a blood sample. So before that, always do the hand hygiene, because you all must agree with me that our hands, they are the vehicle for the transmission of the microorganism, and that is the most common way of transmission of the infections in the hospital, especially the MDROs. Then before inserting a peripheral venous catheter, so whenever you are going to put a venous catheter, either in the emergency or in the ward, whenever, even in your hurry, just do a hand rub properly. Then before or after palpating the insertion site. So before putting the catheter, you are ensuring the site. So before palpating, even if by chance you have selected the site and then again do the palpation, then again do the hand hygiene. Changing the dressings, or either repairing the catheter. Then after doing all the procedure, after the removing the gloves, that is also very, very important. So basically the patient life is in your hand before the care, after the care, and during the care. So all of you know the hand hygiene techniques. Basically, it is alcohol-based hand rub. Whenever your hands are not visibly soiled, always rub all the surfaces and till your hands are completely dry. This is a very important part, drying, because that is the time for the disinfection to work. And second thing, if any of the disinfectant on your hands, this will enter through the catheter into the veins, and that will cause the chemical phlebitis also. Second thing is by the soap and water that must be used when your hands are visibly dirty or contaminated. Duration at least minimum 20 seconds, and healthcare workers should not wear any artificial nails when caring for the high risk patients, because again, these are the source of infection. Then another important point in the aseptic care is non-touch technique, aseptic non-touch technique. This technique ensures that whatever thing you are using, like the needleless connectors or the tubing, or you are doing the flushing of the lines, this ensures that the key part of that must be protected from the contamination during your process. So you can wear the sterile gloves if it is very necessary to touch the key parts, or otherwise the clean non-sterile gloves may be used for the general insertion. So when this technique must be used, whenever you are putting an IV catheter, placing or flushing it, or you are putting a lock into the catheter, then whenever you are changing the caps, needles or the tubing, when you are preparing the IV medication, because these medications you are directly putting into through the lines, so they are also the source of the, maybe if you are not taking the proper precaution, then they may be the source of infection. And definitely when you are putting the CVP, central venous catheters. Next. So in the aseptic technique, the number one is the, again, strict hand hygiene. Perform immediately before and after any handling of IV sites or the equipment. The second important part is the skin disinfection. Always use more than 0.5% chlorhexidine with alcohol, and do it from center towards the periphery outward in a concentric circles, and again allow it to dry completely, so that this disinfectant must work properly. Then use the maximum sterile barriers, especially during the, if you are putting a central venous catheter, the full one, the full body drape, sterile gowns, mask, and the caps. Next. Then what is no touch handling of sterile equipment? That is to protect the key parts. Already I said that the tips, syringe tips, which directly enters into the vein, the needleless connectors. Then these to be never touched with your hands, bare hands, or they should not come in touch with the unsterile surfaces. So this is a no touch handling. Then use of, after putting the catheter, use of sterile dressings. Always apply a semi-transparent sterile dressing. And if it becomes soiled or damp or loosened, then replace it immediately. Then use of sterile supplies. Whatever supplies you are using, like if you are putting a dressing, that should be a sterile one. Then the catheter, please check that it is unopened. Then IV set. So, or whatever supplies you are using, they must be the sterile one. Then always discard the single-use vials after one use. Never touch the tip of a syringe or the hub of a catheter. Again, one important thing, ensure that all IV medications which you are administering through the catheter, they must be prepared in a designated clean area. So in this way, maintain a clean, prepared field. Next. The other essential IV line care practices are hub disinfection. This is very important. Always scrub the hub before every entry. That means use a 2% chlorhexidine and 70% alcohol for at least 15 seconds, and using a bidirectional strokes. Whenever you are accessing a needleless connector, you are putting a needleless connector, you are accessing a port or a catheter hub. So before every entry, it is must. Then there comes the certain preventive caps by many companies, and these are the basically antiseptic containing caps. They are known as alcohol caps, and they should be, whenever these ports they are not in the use, then these caps to be kept on these ports so they maintain the sterility. Safe showering is another one very important. Every patient must be advised regarding this, the patient education. Cover the dressing completely with plastic and tape to prevent it from getting the wet during the showers. That is very important. Then do not allow the ends of IV tubings to hang on to touch the non-sterile surfaces. Many of the times when we are going to our wards and this, it happens, we saw that they are touching the table or the patient's bed or they are hanging like this. So they are again the source of the contamination. Next. Next. So one important aspect apart from the lines is the aseptic preparation of the IV medication. Again, the hand hygiene is the first step. Always wash your hands with the soap and water or use the alcohol gel before and after the preparation of the medication. The area where you are preparing your medication must be clean. The tray must be clean. The workspace must be clean. Can do the cleaning with alcohol wipe. Then never touch the sterile components such as the needle hubs, syringe strips, or the rubber bungs of the medication vial. Wipe the vial tops whenever you are taking out the medication from the vial. Before that, first wipe the vial tops or the ampule if you are breaking an ampule next, or the injection ports with 2% chlorhexidine or 70% isopropyl alcohol for 10 to 15 seconds and allow to dry it completely, at least for the 30 seconds. So this is very important step. Next. Equipment integrity, again, always use a new sterile syringe and needle for every patient. Do not reuse. Single-use policy must adhere single dose vial, bags, and bottles. Never enter a vial with a used needle or the syringe because that is again maybe the source of the infection, and you enter the microorganism inside that vial. Ampule safety, use a filter needle when withdrawing a medication from a glass ampule so that this will prevent the particles from entering the syringe. One important part is the preparation of the chemotherapy medications. Always they should be prepared in a clean room or in a laminar flow. Possibly it should be a BSL-2 and at least 6 inches inside the hood so that it will prevent the air from contaminating the sterile field, and avoid placing the objects in front of the HEPA filter so that the proper airflow must be maintained inside the laminar airflow. If there is a sign of the infection, you must report and you must do the daily assessment of the sites. This is very important. And if you find any of the sign of the infection or like the redness, swelling, pain or tenderness, any drainage or ooze, if the patient complains of any fever or chills or unexplained discomfort, immediately it should be reported to the clinician or your healthcare provider. Few words regarding the phlebitis. I know you all are very much master in this, but I must tell something because I'm on the peripheral cannula. So few words regarding this. It is basically an inflammation of a vein, pain, swelling, redness, and cause the pain, swelling, redness, and a warm, tender cord-like sensation. The incidence is between 9% and 30% in hospital settings. Although it is a minor complication, but it causes significant discomfort. Many of the times, patient forgot the major to major surgery, but whenever he returns to the OPD, he always complains of that phlebitis. So it is a big significant discomfort and one of the dissatisfaction cause for the patients also, negative feedback from the patients also. And definitely it increases the nursing workload. It is a precursor of the CRBSI and risk is highest between 48 to 96 hours of post-insertion. Most commonly, the grade 2 is the most common type of the phlebitis, pain, erythema, and swelling. Female genders, because the virtue of their skin and all, they are the independent risk factor. Other risk factors are the older age, the comorbidities like the diabetes, cancers. These are the other risk factors. Basically, the superficial phlebitis, which is a superficial thrombophlebitis, mainly affects the superficial veins. Day-to-day practices, we come to know these, and most common cause is our cannula, irritation from the intravenous catheters. Then DVT, deep vein thrombosis, this affects mainly the larger veins, that is the more troublesome one. And then the septic phlebitis, which is a rare but is a very severe form whenever the clot becomes infected by the bacteria. By the origin, it is of three types, like the mechanical, most commonly by the needle and the catheter, then the chemical phlebitis, irritation mainly from the medications which are administered through the IV, and the infectious, this is by the bacterial infection. Few words regarding the chemical phlebitis. As a nurse, we should know what are the different chemicals which cause the chemical phlebitis. So they must not be either to be very cautiously, it should be administered or should not be administered through the peripheral lines. They are irritating medications or the fluids like the antibiotics, potassium chloride, and chemotherapy drugs. Most commonly, they are known as the causes for the chemical phlebitis. Then high and low pH solutions, pH less than 5, greater than 9, they trigger the inflammations. Hypertonic solutions with high osmolality, they also cause the irritation. And whenever, if you are putting a medication which is not sufficiently diluted, properly diluted, then that can also lead to the chemical irritation. Then drug like the vasopressors, which can restrict the blood flow in the vessel, they are also known for the chemical phlebitis. And last but not the least, it's our antiseptics like the alcohol or the chlorhexidine, which we are putting to disinfect our skin. And if we will not allow them to dry fully, they can drag into the vein and they can cause the chemical phlebitis. Then how we can grade the phlebitis? It is by the visual infusion phlebitis score, VIP score. According to this is mainly graded between 0 to 5. And according to that grades, the action is on, according to the grade, the action we can take. 0 is the healthy side, no signs of phlebitis, just observe the cannula. Number 1, grade 1 is possible first signs, that is the slight pain or redness near the site. Grade 2 is early stage of the phlebitis. In this, the pain, erythema, and or maybe or may not be swelling is there. Recite the cannula. Then grade 3 is medium stage, that is pain along the path, full path, then erythema and induration also. Again, recite the cannula and initiate treatment. Grade 4 is advanced stage, that is pain, erythema, induration, palpable venous spot. Recite the cannula. And grade 5 is the highest form, severe thrombophlebitis, which above all means pain, erythema, induration, cord. There is a pyrexia and a fever also. So again, remove the cannula and do the treatment according to that. So this is the visual infusion phlebitis score. What are the key preventive measures for this? How to prevent the phlebitis initially and the management? It should be always replace the peripheral venous catheter whenever it is clinically indicated. That means if there is a sign of phlebitis or if you are suspecting a blockage, immediately remove it. Not wait for the 72 or 96-hour protocol. So this is known as the clinically indicated removal of the PIVCs. Then always adhere to the aseptic technique. That means the proper disinfection, sterile technique during the insertion. These are the crucial factors. This will prevent the bacterial phlebitis. Site selection, you all know very well that the preferring the forearm over the hand or the cubital fossa, that will reduces the mechanical irritation. Whenever you try to minimize limit the access. The more the access, the more the chances of the infection. Minimum opening to the line reduces the contamination. And the very important is the daily assessment. Daily assessment is mainly for checking the IV site for any of the sign of the phlebitis, and also to ensure whether this IV line is still necessary or we can remove it immediately, because the more the duration, the more the chances of the infection. This is applied with the PIVC also. Every device, if it is to be kept a longer time, the day by day, the chances of infection will increase. So as soon as if it is not needed, it should be removed. Next. Management of the IV phlebitis, that is immediately stop the infusion, remove the catheter, apply the warm, moist compress, and some protocols also suggest the alternating the hot and cold, elevate the affected limb to reduce the edema and discomfort, NSAIDs to be given, topical gels to be applied, and insert a new catheter in a different vein, preferably into the opposite limb. Next. Management of IV infection, again, remove the catheter. If there is a purulent discharge, send it for the culture. Initiate the broad spectrum antibiotic. If the patient's fever continues, infection is spreading, and it is giving the sign of the septic thrombophlebitis, immediately start the broad spectrum antibiotics. Always monitor for the sign of the systemic infection or the sepsis. And if there is an abscess in the vein line, then do the surgical consultation. One important part is the patient education. If the patient is going with the IV line to the home, then please educate the patient and or his or her attendants regarding these points. If whenever they are accessing the IV line, do the first hand hygiene, daily catheter flushing, keep the site dry during the bathing, monitor the signs of infection, and then keep the tubing secure. And if there is any of the signs, then immediately contact to the medical hospital, to the medical staff or to a nurse or to a keep the emergency contact number so that they can contact the hospital directly. So patient education, especially the patients with the IV lines going to the home, it's very important to give these important points to their nurse or to their attendants or who are taking care of those patients. So this patient education is also a very important part of this. So this is a PVC checklist must be what we are following in our hospital, and it is a daily assessment checklist for the peripheral vascular catheter, and I should say that must be followed by every nurse, whoever with the patient with the IV peripheral IV catheter. So my key take-home message for the IV care is that infection control is paramount. Hand hygiene first. Always scrub the hub, keep the dressing dry and intact. Daily inspection, daily assessment, very necessary to check for the any signs, to remove for the early removal of the line. Never reuse any equipment. Ask for daily reevaluation and always maintain the sterility of the IV site. Thank you very much. Thanks a lot.
Thank you, Dr. Sabha ma'am, for insightful presentation. You have emphasizes on infection control, IV care, which is very critical for patient safety. Hand hygiene is very, very important. Follow aseptic non-touch technique is important, and always scrub the hub before access. Thank you so much, ma'am. Uh, our CEO, INS, Colonel Binu Sharma ma'am is here with us. So I request ma'am to show some light on the IV talk in INS. I welcome you, ma'am.
Thank you, Shakuntala, and thank you, Pooja from Polymed. First of all, my apologies to not come in the beginning of the webinar. I was into something else and just couldn't exit. So I was listening for last 10 minutes to Dr. Sabha's presentation. What a fantastic presentation and highly simplified key messages, summarizing it well. You know, IV line, every drop, every line matters to us as IV nurses, as infusion nurses, and as nursing professionals. I represent INS India. It's been in the country for more than 15 years. And the only thing we are emphasizing, we are passionate about that every infusion should end with zero harm, no infections, no complications. And if there are complications, these get reported immediately, action gets taken so that corrective and preventive measures can be taken. At the outset, let me thank our two new chapters, Chhattisgarh and Madhya Pradesh, for hosting it together. Collaboration is the key to success in anything, and even in patient care, collaboration is the key. So, thank you both the chapter officials and the speakers for coming together. And Polymath's initiative, along with INS, it's a highly successful initiative, if I may say. We are about 14, 15, 16 months old. We started it last year, January, February, and more than 200, 300 people join every month and go back with so many clinical takeaways to elevate the standard of care. So that's giving me a lot of satisfaction, a lot of gratification that we are doing justice to the mission and vision of infusion nursing standards of practice. All of you know something about INS, but since INS is very, very close to my soul now, let me again put across that infusion nursing is a highly progressive society which works in the field of educating clinicians, not just with knowledge, not just by providing standards of practice, but also through hands on skills, skillathons, webinars, leadership lessons. We do so many things through INS. You'll be amazed to know the initiatives of INS across the country. We've got about 20 state chapters, and we are scaling up every year, adding 3 to 4 new chapters. Chapter means every state has a group of officials, chair, co-chair, scientific manager, a state secretary. That is a state level organogram. We've got a national level organogram where you have the CEO, the president, the national secretary. We have got a governing council to take key decisions. We've got a general council. We have got a editorial board to look at the standards, at the technical content. And INS has got 4 industry partners. These are healthcare industries. They've got 3M, BD, Polymed, and B Brown. Now you would wonder why a nursing society has industry partners. So I would have loved to hear from all of you, but let me just put it this way. Healthcare industry partners, they first of all, the products they have align with infusion, whether it is IV cannula, whether these are IV sets, IV fluids. So these align well with INS scope of work. Industry partners have got a very high penetration across the country. They help us to penetrate higher and higher to more hospitals, to more people, so that more and more nurses and nursing leadership gets to know about INS standard of practice. So thank you all INS partners for that.
ও কথা বলবে, ও অনেক কথা বলবে, আমরা বেশি বিয়ে করছি তো ওই জন্য।
ज्यादा कथा नहीं बोलो, please mute yourself, Madhukari. Okay, so we work with these partners in so many ways. We have got a lot of fundamental certification programs relative to vascular access device management. We have got a 6 weeks comprehensive program for certification, which was launched in the month of January this year on the occasion of IV Nurses Day. We have got a electronic newsletter where you can share all your initiatives, all your activities, and any best practices. You can send it any time to the INS chair, to the iNews chair, which is Ms. Dolly Vishwas. You can also share it with Ms. Pooja, who is also part of the iNews, and there are many more people in that. We do an annual quiz, which is known as the Mastermind Quiz, which is hosted along with BD, where about 25,000 nurses participate. We will be doing that sometimes in the month of September, October before the conference. We do a quality improvement based project certification, which is known as Infuse, Almost 100 hospitals in the country have gone through a Infuse certification, which is a voluntary certification. Assessors will come to you. We support you to go through the journey. That is to elevate the standard of infusion care in your hospital. If you have a ICU in your hospital, which I'm sure no hospital is without a ICU, then it becomes imperative that you elevate the standard, safety, and excellence in infusion. You must opt for infuse. It's a voluntary exercise. You can register yourself. We help you with all the required documents, SOPs, checklists. We help you get ready over 3, 4, 5, 6 months. And then once you say that you are ready for the final assessment, then a team of two assessors will go. This we host along with one of our partners, 3M. We also do a quality improvement program, which is known as Inspire, that is done along with BD, where we help you to identify pain areas relevant to infection control, relevant to infusion safety, relevant to vascular access device management. You can identify your pain point. We help you design with a template, a QIP, and we will review the QIPs. We do an evaluation, a scorecard. You get rewarded. We also do infection control summits, lead next program with BBRON, leadership summit. We have another partner, ebec med. With them we do a training excellence series. We have a simulation partner. So many activities, so many different flavor of program, everything to elevate knowledge of nurses, competencies of nurses, so that we can give outstanding patient care when patients come to our hospital, because every line matters to us. Every single patient who comes to a hospital gets a IV line, gets a phlebotomy done. If that is the case, right from a peripheral IV line to a central line to an arterial line to a PIC line to a midline catheter to a dialysis catheter, the the case is endless. INS works in all of these areas. And I urge all of you to become part of Infusion Nursing Society, so that you are able to get the benefit of all the programs being hosted. You can plan skillathons in your hospital. You can plan skillathon in your college. We've got a very nominal membership for the students. We call it INS Yuva. It is only 499 rupees. For a lifetime member, nurses can become lifetime member, 5-year member. More and more people become member, more and more knowledge you will get. You can procure the standard of practice. A printed book on standard of practice is available, which is the latest version of 2025. You can write to the INS manager. You can write to your chapter officials of MP, Chhattisgarh, to anybody. You can write that you need the copy of these standards. You can apply for Infuse. And we are scaling up more and more initiatives through INS. Also, we are coming up with our annual conference. We have already hosted 13 annual conferences in the past. And this year we are coming up in Ahmedabad. There will be so many competition events announced 4 months prior to the conference. The conference is in November. It's on 27th and 28th November in the city of Ahmedabad. We wish to see many, many, many of you taking part in the conference and competitions, poster, elocution, best paper, best innovation. A lot of competitions will happen, not just for nurses, but also for students. INS is a great platform to network. You will get to meet the entire leadership of the country, the nursing leadership, the medical leadership. So many people come for the INS conference. We have a hybrid model. We also have the conference in person and live online. So you can opt for whatever is suitable to you. Infusion Nursing Society is a not-for-profit platform. So everything we do is to raise the standard of nursing in the country. And you know the International Nurses Day theme. Empowered nurses save lives. How do we empower nurses? By making them more knowledgeable, making them more competent, making them aware of the global standard, the international benchmarks. This is what INS does. So we help you to get your nurses elevated to a different level, empowered, so that they can save lives, they can save patients, they can minimize complications. Thank you, everybody, for hosting a wonderful webinar today. Thank you, Shakuntala. Thank you, MP chapter people, Vinci, and everybody. Thank you, Chhattisgarh team. I can see Colonel Chavi also there. Sorry, I may not remember all the names, but I can see so many teams joining the webinar along with a bunch of their team members. My heart swells with pride seeing such a fantastic response to our webinars. And let me tell you, next month in the month of May, because it's a special month for nurses, I'm hosting a webinar on INS, which will talk about healthcare communication with patients. We are doing it in collaboration with Patients for Patient Safety Foundation. We will also be doing, that will be about an hour, and a 30-minute session in the same webinar on helping you to plan your financial life. We don't want to work with you only for IV. We want you to grow in every aspect of life. Whatever money you are earning, you should know how to invest it, how to spend it, how to grow your money, grow professionally, grow personally, grow financially, and all the very best to each one of you. Thank you so much.
Thank you so much, Binu ma'am, for the brief and insightful introduction to INS. It provided a clear understanding of the organization, vision, mission, and vital role in strengthening nursing excellence and patient safety. We truly appreciate the valuable overview and guidance. Thank you so much, ma'am. Uh,
Thank you
moving
very much.
ahead, moving ahead, I welcome Dr. Rahul Pratap Prajapati, consultant infectious disease. It's a hospital. The topic is Bundle of for Safety, Collapse Prevention in Action. I welcome you, sir. Over to you.
Thank you, ma'am. Thank you for the invitation and giving me this opportunity.
Thank you,
And
Dr. Rahul. I was just looking for more doctors to come into our webinars, and you are fulfilling my wish list for the first month of the financial year. Thank you.
yeah, thank you, ma'am. Thank you, ma'am. And good afternoon to all of you. And already it was very wonderful talk already delivered by all the speakers, Dr. Sabha ma'am, Binu ma'am. So I think so much of things already have been told, and that was very much enough. So for me, there's nothing left to add, but I'll try to add something from my perspective. If possible, anyone can please share the slides.
Pooja, can you please share?
Yes. I'm just asking. Ipshita, you can please share that from your side. Thank you.
Meanwhile, when the slides are being shared, Dr. Rahul, we are planning to create an advisory committee on infection prevention and control on the platform of INS. I'll definitely connect with you on that.
Yeah, sure, ma'am, sure. It will be a pleasure.
Yeah.
So we are trying to share it. There is some glitches coming in. You can start. I'll just, in the meanwhile, we'll just do the backup from their side.
Okay.
Yeah.
So basically, what we have this as a complication of this IV lines, especially with the central lines, this CLAPSI. CLAPSI, we know that this is a central line associated bloodstream infection. So to all of you, being this definition, what is central line associated bloodstream infection? Is actually this is a primary bloodstream infection to a patient who had a central line within 48 hour of period before the development of this bloodstream infection. So within the 48 hour of getting this bloodstream infection, and it is not related to any other infection at the any other site. So we termed it as a central line associated bloodstream infection. So this is a very a term. It's actually a vague term for, and it is a more importantly, it is utilized as a surveillance term because it gives exactly not the term which is related to the catheter only. So maybe there is some hidden infection is there and the patient is having central line, so they may be having this term as a central line associated bloodstream infection. The more accurate term is that CRBSI, which is catheter related bloodstream infection, which is more accurate. But to differ with this confusion, that's INS standard has already been given a term which is common name is given this catheter associated bloodstream infection. So CABSI we can use just not to confuse. So both the central line associated and catheter related are actually the same, but giving a more correct information with the CRBSI. So we are going with this CLAPSI. So we have already seen that the information there is increasing prevalence of this CLAPSI there in the Indian scenarios. Especially we have seen in this Indian hospital acquired infection network. The rate is almost 8.3 per thousand central line days is there, which is average of 4.11 thousand central line days. So there is a very much significant number of cases of CLAPSI is there. So the important thing is that why this CLAPSI is important to us, like in India or in some other part of the world also. So the important thing is that the global data what we have is actually showing this across all the major hospitals and ICUs over this continent, subcontinent. We have seen that increasing number of this central lines, 8.3 per 1,000, and nearly about all those patients who are having this CLAPSI as a complication, they have nearly 40% of the patients. If, very correctly, I will say that this is 37.7% of patients with CLAPSI have mortality. So there is a huge number of mortality associated with this CLAPSI. So that is why it is very important to talk about it and take an action for that. So apart from that, CLAPSI, the mortality is associated with so many other things also, like the patients who have this CLAPSI infections. You can see that up to 60% of cases, the infections are associated with the MDR organism. Especially in India, you will see this Klebsiella, Acinetobacter baumannii, which is carbapenem resistant, and some other infection like Pseudomonas is there. So mostly they are very much of MDR organism are there, which complicates, and there is a significant drug resistance is overcoming with this infections, which is hospital acquired. Apart from that, this thing, there is a huge economic impact also with this thing because increasing number of infections and complication leading to multiple other things like increasing the hospital stay. So that ultimately this economic impact is also there. So that is also one thing which actually gives an importance towards the management of and prevention of this collapse. So this is how it is important. So what could be the sources? How we can get, like we are doing in and out these practices inside the hospitals and critical care. Please refer to the next slide. So there are some possibilities that there we can have this infection. There are possible sources of infections. We can summarize it in the four different mechanism of these sources. Can you please refer to next slide? So the one is while the first thing that is important where we can get these infections or CLEPSI, like during the catheter insertion, while you are inserting the catheter or the dwell time, the time when it is there. So the migration of all those microbes which are there in on your skin, so those colonizers or commensals are there. So they can goes down or if there is an infection over the in skin. So during the catheter insertion, they can travel down to the catheter tract and go into the bloodstream. So that is how the most common mode of this source of this CLAPSI is there. Other thing is that the second thing is While the catheter hub, the lumen, when we use in the routine practice, we administer the drugs or other substance. So while administering this thing, the manipulation of hub or lumen actually leads to this infection. So there is a colonization of the bacteria or some like hand hygiene practice is not adequate. So in that case, while manipulating this, we can get this collapse through this infection source. Other thing is that maybe you can be having some endogenous microorganisms which are there. So this catheter is an external environment for them, and they have certain MDR organism are there which have this tendency to form the biofilm and colonization. So they become a nidus for further infection and to lead to this catheter related bloodstream infection. And the fourth, very less common, that from the contaminated infusers, which is very less rarely we can see this, but this is another possibility. So we have to be aware of all these four things. So we have to target when we come to management and prevention of this collapse. We have to definitely look for these four things. Um, now we have this possibility of collapse in and out in the critical care. So we can suspect in those patients who are already having this uh, clinical signs of sepsis with there is a line in situ. So when we are suspecting, how can we come to the point where we can say that definitely this is a collapse? So we need a definitive diagnosis. So there is a apart from this clinical signs of sepsis, we have three different things. Among which any one of them is there, we can say that yes, there is a definitive diagnosis of this collapse is there. So what are those three different things? You can see that there's a positive semi-quantitative or quantitative culture from a catheter segment. So we can have this sample and the same organism isolated peripherally. So the same organism from the peripheral sites and from the catheter site. So we have this. There is a quantity of quantitative evaluation can be done by this presence of 10 to the power 3, more than 10 to the power 3 colony forming units if there. So we can say that this is a significant growth is there. Apart from that, a simultaneously quantitative blood culture with a ratio of 3:1. So more than three times of a colony is there in the central venous associated devices. So that can give an impression that definitely there is a central line associated bloodstream infection. Apart from that, the timing is very important. So while the culture, the time, the positivity differences should not be more than 2 hours from the peripheral culture. So in central venous access devices, the growth is earliest as compared to the peripheral culture. So any one of the three associated with the sign and symptoms of the sepsis in a patient who is having central line in situ. So they must be kept as diagnosis of CLABSI or central line associated bloodstream infection. So what is important? So you have diagnosed, you know that what is CLABSI, you know what is the possibilities by which you can get this CLABSI in the hospital to the patients, and what are the different criteria we can diagnose. So what is important now is once you are having this suspicion or possibility of this thing, you need a proper surveillance with the teams to identify at the time earliest when you are getting this infections. So there are certain role of this surveillance which is very important for the management and prevention. So it is basically playing the critical role in the detection, reporting, and prevention of collapse. How? So there are certain key elements. So first of all, you have to have this standardized definitions. So once you have a standardized definitions, definitely you will not you will be getting this accurate information of what is the rate of this collapse, what are the incidence and prevalence of collapse in your institute or your whatever you are there. So particularly, there are certain guidelines have been given by which if you are isolating a pathogen, it is true pathogen. So only one blood culture is enough to say that there is a significant growth is there. Or if the commensal is there or the normal skin flora is there, then at least two matching sample you need for the from the blood culture to identify it as a collapse. So this is how you have to have this standardized definitions to confirm the diagnosis. Apart from that, when you are getting these infections in your practices or it is there in your hospital critical care, so you have certain other surveillance key elements like device utilization ratio is one thing where you can calculate it as a number of central line days uh, per number of patient days. So the number of patient days, how much it is, and number of central line days. So it gives a reflection of this possibility of or risk of getting this CLABSI. And also you can have this CLABSI rate, that is number of CLABSI per number of central line days into 1000. So you can get this CLABSI rate also. This can also be giving you an impression that how much you are in this part of prevention and how you are going to manage all these things. Apart from that, you have another this microbiological surveillance is there. So the regular identification of pathogen is important, and antimicrobial susceptibility is also important to manage and further making an policy towards the antibiotic therapy also. So there is a three different type of surveillance, like active surveillance is there, which is very important and very needful. So you have to be very vigilant to all those day-to-day routine of and monitoring of the patient. So you have to be have this proactive case identification through manual charts, reviews, and direct chart reviews. So active surveillance is very much important. There's passive surveillance important also relies on healthcare. So if anyone is getting some infection and they can reporting it. So this is a passive surveillance, but there is always chance of missed information. If somebody is not reporting it, we have this missed information. So apart from that, the trigger-based some automated surveillance is also there. Like somebody is already having previously some infection and is very prone to certain risk factor. So in that case, this trigger-based surveillance for a specific cases can also be done. So those who are having very potential cases for the and the lastly, the surveillance part, we have this data analysis and feedback, which is very important. What you are seeing, you have to report it and you have to analyze. And the feedback mechanism is very important. That gives you a chance to prevent, to make a policies and timely management of the complications. So this is how the surveillance part of diagnosing this is very important and everyone is the part of this problem in the surveillance. So what is the impact of this surveillance? Why we are doing it? So the surveillance data actually this directly inform the prevention strategies. So based on the surveillance data, we can make a prevention strategies. So this feedback on CLAPSI, so they gives us an possibility to prompt this making this possibility of this insertion bundle implementation and reducing infection. So this lead to in some studies we have seen that this mechanism of surveillance and that lead to the prevention bundles, which actually reduces the infection by up to 66% in many settings. So this is a very huge impact of this surveillance of this thing, and this gives a very much help in the prevention strategies. So now, if we are having this possibility of in any facility that we can prevent it, so what should be the prevention strategies? That is the most important thing. How we can prevent and what should be the exactly what we can do in a very composite manner. So there are certain general principles of management or prevention strategies like in CLABSI or this device associated infections we are having in hospitals. So the three things which is very important, like the placement of this devices, like appropriate indication should be there, proper insertion technique should be there, and in maintenance we have to take care of the device and when the removal when it is not required. So it is important to identify when it is not required and when the signs are there where we have to remove it. So we have to compositely looking at all the part of this thing. So basically in five different terms we can say the general things which are very needed, very much needed, like strict adherence to sterile techniques we have to use, and minimizing the device use. So where it is not required we need not to use. Hand hygiene, already it has been very much elaborately covered by Dr. Sabaman. So hand hygiene is very important to all of us. related to the healthcare professional. And the fourth one is education and training to all of who are working in and out in the hospital environment, who are coming to the hospitals and who are newly appointing. So every time the education and training should be one key part of the general principles. And again, the antimicrobial is towards it. So when we are using these antimicrobials judiciously and not for all the patients, so longer duration of treatment without any reason. So they are the reason to get this infection again and the production of this MDR infections in multiple ways. So these are the general principle by which we can prevent this class infection. So now what we can do with apart from this general approach. So we have a bundle approach. So if we are doing apart from these five different things, if we are counting it as one, two, three, four, five, and we are doing okay, two we are doing, three we are doing, okay, ये तो दो नहीं कर पा रहे हैं. So in that case, is there is no chance of your going to improve your quality. So you have to have all or none. You have to do it all evidence. So this is why this bundle approach is required. So everything should be covered in that bundle approach. Then only you will get the benefits and impact of this thing. So if any part is bridged, there is a complete bridge is there. So the bundle are actually the sets of evidence-based practices that when performed collectively and consistently. So you have to be very much I'm give weightage to these two terms, this collectively and consistently. So then only you will get the better outcomes than they are implemented individually. So someday you are using some day you are following, someday you are not following, then it is not going to give you benefits. So this is collectively and consistently. So this bundle approach should be followed. So majorly we have two different type of bundles approach like insertion and maintenance. So while we are inserting these devices and while we are maintaining these devices. So we have this complete bundle approach for them. So coming to the specific insertion bundle practices which are required. So we have to follow these six specific practices while we are inserting these devices. So first is use an all-inclusive catheter cart or kit. So whenever you are going to put a line, so you have all the necessary things at that place so that you have go through the protocol with all the things. So all inclusive catheter kit should be there. You should not be compromised with any time with these things. Apart from that, skin antisepsis at the insertion site with 2% chlorhexidine alcohol, which is very much important. This antisepsis is while you are putting these devices. Again, this that we have already discussed this four different part by which we can get infection. This take care of the first one. Third is the large sterile drape, like cover the patient's entire body. So it's not just the part we have covered where we are doing all this procedure. We have to cover the whole patient's body so that there's no chance of getting infection from anywhere in any means. That is also one important thing in this insertion bundle. The fourth one is that optimal site selection. The site selection is very important. So you should not go by the ease of your practice. You should go by the which is the best thing we can do to prevent the infection. So putting this central venous devices, you have to go with the preferentially, you have to go with the subclavian and internal jugular later on, and lastly you have to pick femoral vein. So this is how you have to choose this site to prevent this infection. So more you go with the femoral vein, there is a high chances of getting this collapse rate. And the fifth one is that the use of ultrasound guidance catheter insertion. Again, which is very important practice, and we are doing it. And this is not a very big issue to do all those things. So we have to practice it. It prevents this repeated puncture of the vein and phlebitis, and that lead to this infection and further complications. So this is how we can use this ultrasound guided catheter insertion. And the last one is that the use of transparent dressings with chlorhexidine gel or pads we can use routinely so that there is a visible signs of infection if it is there, you can early get it. And gauze dressing also we can use, but only if there is a pressure dressing is required. So better we have to go with this transparent dressings preferably. So this is how this all these six specific insertion bundles practice we should follow to prevent this catheter line associated infection. Again, if you are coming to this after this insertion bundle, what is important is the maintenance bundle. There is a specific maintenance bundle practices, like five important points we have to take care of, like to especially those who are working in and out in the critical care, the nurses and the providers and the leaders, everyone should look for a regularly inspect and change the dressing every 7 days. If you are using a transparent dressing, and if you are using the gauze dressing, then every 2 days you have to change the this dressing. Apart from that, if it is soiled in any ways by the blood or any body fluid, if it is there, so immediately you have to change it as early as possible. So this practice should be there. And apart from that, the second thing is that disinfection of catheter hubs, which is very important in some cases. We have seen that while you are manipulating these hubs, you're using it. The nurses, like we are putting some other IV line to that thing. So while manipulating, there is a always chance of this colonization of these hubs with certain bacteria which is there in the hospital environment, which are sometimes maybe the commensal also, maybe some MDR organism by the contamination. So in that cases, if you don't disinfect this catheter hubs, definitely you are going to give an increased risk to the patient that they may have this catheter-related bloodstream infection through that. Apart from that, the routine replacement of or administration sets for non-blood or lipid products. Second is so every time you should not use the same this administration set. So you have to change it every time so that there should not be any colonization that go through the catheter and lead to the bloodstream infection. And apart from that, this minimize the line manipulation. So if it is not required, don't manipulate it. So try to maintain a closed system. So that can also help you to prevent this collapsing. And also you can do in the maintenance, like if patient is for a prolonged hospital stay, you have to have this daily chlorhexidine bathing for the ICU patients, especially more than 2 month age of like children's also, not for the this units. So we can use this insertion and these maintenance bundles very strictly to prevent this infections like CLABSI in hospitalized patients. So these are the most important thing. So apart from that, there are certain standard practice recommendations also that we should follow, and we should look for certain things like the first one is that the assess the this vascular associated device insertion and insertion and exit sites both for the signs and symptoms of vascular access device related infection like CLABSI. So what are those signs we have already seen in the previous slides that the erythema may be there, you can see in the patients where the insertion site, edema may be there, pain or tenderness, or if there is any drainage from the site, any fluid filled pocket is there beneath, or there is a in the tunnel of a total implanted intravascular devices. So in that cases, you have to be very vigilant. Is there if there is any induration or is there a drainage or a skin breakout is there? In that case, you have to be very much sure that there is chances of infection and complication is there. So also, if the patient who are having these lines and having fever also, which is not explained by any other infection, so in that case also you have to be very vigilant that there is a possibility of this central line associated bloodstream infection. So this is the one thing that you have to look for. Apart from that, the use of antimicrobial catheter is also one thing which we can do to prevent and reduce the risk of this CLABSI to the high risk patient, those patients who are for the prolonged period of this requirement of this central line. So in that cases, we can use antimicrobial impregnated catheters also. Apart from that, the use of chlorhexidine impregnated dressings that can be used in all the patients above 18 years of age. So this is one again more thing that which can prevent the colonization of bacteria or giving an opportunity to get this acquiring these infections. So we can use in older patients like more adult patients. However, it is not till now. It is not recommended in neonates because their skin is very sensitive and it can create some issues with that thing. So we can avoid in the neonates, but in older adult patients we can use this thing. And apart from that, you have to consider the daily use of fluoridation bathing. We have already discussed this recommendation. And next is the removal of peripheral intravenous catheter. If the patient develops symptoms of this, certain complications or failures like infections, which like tenderness is there, redness is there. So if you see all those things are there, then you have to remove this peripheral intravenous catheter. So to prevent this further complication leading to cellulitis or some phlebitis or some infection that lead to thrombosis also. So in that cases, you have to be very vigilant and remove it as soon as possible. Uh, Next is that so all those apart from this peripheral intravenous catheter, we can remove it very easily if we can change it to some other place. But it is not exactly same with the central venous catheter. So we have a limited access, and sometimes it is very difficult to put a different line also. Patient is very sick in certain condition. It is difficult to manage in those conditions where we have this possibility of central line infection. And so when to salvage and when to remove, this is a question mark is always there. So in that cases, there is certain condition where you can salvage the catheter. So if there is a CAPC is confirmed and the patient is hemodynamically stable, in that cases, we can salvage the catheter. Or if the patient is having uncomplicated CAPC, there is no complication related to the other things like in severe sepsis or anything. Or there is short-term central venous catheter is there. In that cases, you can use the 7 to 14 days of antibiotic therapy and salvage the catheter. Apart from that, if you have this organism like which are not that much virulent, like cons or enterococcus is there, in that cases also we can salvage it, the catheter, especially in the pediatric population. If you are going to salvage the catheter, you have to be very much vigilant, and close monitoring is required for those patients if you are going to anyways trying to salvage the catheter. But in all other cases, like if a patient is having growing this organism like Staph aureus or some gram-negative MDR bacilli are there or Candida infection is there, in that cases you have to remove this catheter anyways. Also, if patient along with CAPC, there is a signs and symptoms of severe sepsis, suppurative thrombophlebitis, endocarditis is there, and if there is not no response with the 72 hour of antibacterial therapy or some resistant organism is there, in all those cases, you have to remove the catheter. So this is how you can differentiate when to salvage, when to remove this catheter. So not, but in just suspecting this catheter related infection, you can should not remove it only by the suspicion. So you have to have a clear-cut diagnosis of this CLAPSI, and if there is any fitting into the criteria, then you can remove it. And also sometimes we try to solve we can put a guide wire and change and exchange this tunnel catheter, non-tunnel catheter. So that practice is also there, but this is actually not recommended in the cases that the guide wire exchanges practice should not be there. And you should not routinely culture, like every catheter you should not routinely culture the tip, because it may give a colonizer growth will be there, and you will unnecessarily you will be going to give antibiotics based on that. So routine culture is not required for the this catheter tip, but the when there is a suspected capsule, the content from the reservoir you can take it and you can send it for the cultures only when it is suspected. So what we can do, so these are the recommendations are there. We know that how to prevent it. So, and the bundle approach. So what is important? How we bundle up. What is our role? So these are the practices which are there, which are the bundle of the recommendations are there, which we can do. So, but we how as a provider, as a nurses, as a leaders, as a patient or families, how we can bundle up. So we all should know the role of each one of us. Like everyone has some role. So the providers has to order lines only when it is indicated and choose the best site and remove it promptly. When it is not required, remove it. Nurses, they have to maintain the sterile techniques, scrub the hub practice, and advocate for the daily review. Every day you should watch, look at it, whether there is any signs of symptom of infection. Leaders should definitely support the checklist use to the nurses, to the providers, and provide the chlorhexidine gluconate for the use and empower staff to stop unsafe insertion. So all these practices should be there. And also for the patients also, they should also be in that loop, and they have the role that they should speak up if the dressing is loose or there is a side looks red. So we should educate them also if there is anything like that. So this is how we should bundle up, and we should compositely we should do these practices to be followed. So now what? So we know everything. We have discussed everything. We have all the literature, we have data, we have surveillance, we have prevention bundles. But there are certain barriers also. So if those barriers are there, what we can do with these barriers? What are the common barriers like logistics? We have the logistic issues, the site selection problems, the consistency, and the communication. So these four different areas of barriers we have. So what are the clinical excuse usually we see in the clinical practice? Like it takes too much time to gather all the supplies. So this is the logistic. ये कैसे सब हम लेके आए? So that we can solve it by the all-in-one prep kit. So you should have a pre-packed kits should be there containing all the bundled items. So by this way you can prevent it. Apart from that, the femoral vein is easier to access. Sometimes in a hurry, we can go for the femoral vein again. So you have a proper training and pre-stocking to keep subclavian kits on crash cards and provide regular simulation training to all the clinicians, all the providers and the nurses, the clinicians to comfort their pressure so that they can easily use this kits, and they have to be very trained for that thing again. And another excuse is that I simply forgot the scrub the hub during a busy shift. So use this scrub the hub stickers on tubings, and peer reminder should be there. Alcohol impregnated protectors cap for continuous disinfection. So that's how you can promote these scrub the hub practices also. And if there is no one checked if the line was still necessary today, so that should not be there. The daily round make line necessity. Mandatory checkbox should be there in mornings round script. There should be some checklist. Every day you have to do it. And when it is not needed, it has to be pulled out that day. So this is how we can beat the barriers and bundle up. So now call to action to bundle up for the safety. So again, we know that all these things, there is if you are missing a single point in the chain, you are breaking this safety breach. So we need 100% compliance from all of us, like providers, nurses, leaders, and the patients and families. So 100% compliance is required for the insertion and the maintenance bundles. You have to empower any staff to stop the line for the safety. So that should be there. You need not to wait and ask daily, can this line come out today? Every day you have to ask this question every time in the morning round, because this every line, every time, every element, because there is a one infection, it's one too many. So this is very important. Every time you cannot miss the opportunity anytime in this process. So this is how we can prevent. So the tool that we can make it like insertion checklist, we can do the real-time audit during placement, daily goal sheet we should have. What does this patient still need the line to this question? Unit level feedback should be there. Post your CLAPSI rate monthly, and we have to celebrate zero. And simulation training also is very important. So education and training is the uh, key element of this prevention and surveillance and management. So this is how we can prevent all this infection, CLAPSI, and other device-associated infection related to that. So I think there is many more things already being told. So this is from my side only. Uh, so I hope you all have got the, the, the underlying message for this thing. Thank you.
Thank you so much, Dr. Rahul sir, for an excellent and practical session. The key
Thank you.
takeaway for all of us are the critical importance of bundle compliance, strict aseptic technique, continuous surveillance, and daily review of line necessity. Your powerful message, the last slide, every line, every time, and every element truly reinforces our commitment to zero infection and zero compromise. Thank you once again for sharing your expertise and inspiring us to deliver safer, higher, and quality patient care. So let us not just remember this principle, let us practice them in every patient, every shift, and every time. Thank you so much, sir. So moving ahead,
Thank you.
we are having two more sessions. Uh, I welcome Miss Princey Libby, nurse in charge, Bombay Hospital, Indore. The topic is Beyond the Needle, the Art of IV Therapy. I welcome Miss Princey to take over.
Good afternoon, friends. I'm Princey Libby, associated with Bombay Hospital, Indore. As we were hearing from Dr. Sabha, zero infection, and from Dr. Rahul, uh, the prevention, then it's my turn. My topic is Beyond the Needle, the Art of IV Therapy. Beyond the Needle, the Art of IV Therapy, the agenda is Introduction to IV therapy, limitation of traditional IVs, innovation in IV delivery, then benefits of advanced IV solution, future of IV therapy. Introduction to IV therapy, evaluation of IV therapy. What does it mean? Evaluation means the invention of IV therapy, how it happened. In earlier, as we know, the medications were very limited and the scientific foundations and discoveries were done. And in 17th century, the Harvey discovered circulation. And in 1656, the Wren's first successful IV therapy was done into a dog. Then in modern development and application in 19th century, the sterile techniques were introduced, and in 20th century the sterile techniques were continued and widely spread, and the IV therapy, hydration and medicines and nutritions were invented. Then is the Beyond the Needle, the art of assessment and access. The art of IV therapy is, as a nurse we have to be more skilled for intuition and experience, and the site selection and adaptation. These points already been discussed, and as we know, as a nurse, we have to be experienced for selecting the site. As we all know, the elderly patients have fragile skin, fragile vein, and the children who have very thin vein. So, as a nurse, we should uh, decide which catheter we have to introduce, and for that we have to be well experienced. Then next is the art of patient care and comfort. The art of patient care and comfort, it means the whole person to be treated physically, mentally and emotionally. As a nurse, we always deal with the patients, their anxiety, their pain reduction, their empathy. As a nurse, always, as soon as we um, deal with the patients, they tell sister, धीरे से लगाना injection. So their anxiety we can understand, and we should reduce the anxiety by explaining the procedure, their pain reduction we have to focus. Next is the art of vigilance and maintenance. The art of vigilance means the nurse should be alert, the nurse should be more confident enough to insert the catheter, and for that also the experience is needed, and uh, for this, beyond the stick monitoring, the IV catheter should be monitored regular basis, and as we will monitor the IV catheter, the infection will be less, and the safety will be more. Next is the limitation of traditional IVs. Limitation means the boundaries. What boundaries as a nurse we face, as we should not neglect the comfort and the preservation and the complication like already discussed that phlebitis, infiltration, infection, and repeated vein punctures that may lead to trauma, distress, and the outcome will be poor. So the limitation should be thoroughly inspected. Then is the complication and risk. This, these terms already as a nurse we all know very well. The tenderness, the psychological distress, air embolism, infiltration, infection, phlebitis. These all terms we all know and already it has been discussed very well. So we have to look this risk and we should limit the risk. Next is the innovation in IV delivery. IV innovation, the word itself means the micro needle technology, the transforming the patient comfort. In future, we can see the less pain, less anxiety, and the compliance, and this all will be transferred the patient comfort, enhanced delivery mechanism. The microneedle patches, pumps will be introduced. Future application and research, which will include the home IV hydration and medications, which will release less waste and safer medication. Next is use of IV machines. IVIC machines, generally these machines are used in abroad. In India, it's not been very well introduced. These machines are very well advanced, and as a nurse, if we will use these machines, the medication error, the air embolism, all will be less. So, if in future, if as a nurse, if we use these machines, we can deal the patient safety. Next is benefits of advanced IV solution. What all benefits we can have? Enhanced patient experience, that is personalized IV formulation and reduce administration time and improve comfort and safety. Through the enhanced uh, patient experience, it will be based on positive pressure, ensuring art of IV therapy that will provide the outcome very near what the patient expected from us. Then is the improved efficacy and safety. Improved efficacy and safety also need, deal with the patient, that is state of the art system ensure the consist of IV doses, the outcome will be more advanced system will be, as we use the advanced system, the uh, rapid cellular nutrient delivery will be more. This enhances the therapeutic outcome. Next, what is the future of IV therapy? What will be the future? Personalized medicines, the future trends in IV therapy. That is, in future, as we all know, the AI, the ML predicts IV treatment is responding. AI is so much uh, progressing that in future, that in medical profession also the AI will be working more. As we know that uh, the dialysis that is conducting in patients in hospitals. So मेरे ख्याल से आगे जाके पेशेंट्स को डायलिसिस के लिए हॉस्पिटल जाने की जरूरत नहीं पड़ेगी, वो होम में ही ट्रीटमेंट एआई ऐसा कुछ फ्यूचर में लेके आ सकता है, ऐसा मुझे लगता है. Next is home based IV care. The future trends in home based IV care, is advanced infusion devices that streamline IV administration. That is, if the patient will be treated as a homely situation, then the care will be more. The personalized plan boost IV comfort outcomes will be more, and the remote monitoring enables real-time IV patient supervision, and the care will be effective. So, at last, I will conclude my saying that let's not take IV therapy as a task that we are doing. Rather, it should be considered as a art that we need to be skilled professionals in nursing field. Thank you.
Thank you, Ms. Princey, for the insightful session. IV therapy is not just a procedure, it is a critical component of patient safety and quality care. And we have the limited time limit. So now moving to the next session, I welcome Dr. Supriya Mandal, Professor and Nurse Statistician, Sri CM Nursing College, Bhilai, Ms. Hiteshwari, Quality Nurse, Balco Medical Center, Raipur, and their topic is Skill Before Scale, Master IV Therapy Through Simulation. So I welcome both of you. Over to you.
Good afternoon. Me Supriya from Sri CM Nursing College, and Hiteshwari is there from Balco. So we both are there in these sessions. Now I'm having some internet problem. Just 1 minute before I was chatting with Pooja. So Pooja, I'm trying to share my screen. If any problem will occur, then I will let you know.
You suggest, else we have your content. You want me? My colleague Ipshita is there. She can share that from her side.
Okay, I'm trying. One second. So we are starting, will not take too much time. We'll try to focus our main thing. Already we are in behind in time. So my session is that, till now internet was good, but in my time just it started to problem. Yeah. So this session will talk about skill before skill, master IV therapy through simulation. So here we will trying to show OSCE-based peripheral IV cannulation demonstration in critical care. So before starting that, actually something is there that whenever critical IV therapy is not only a procedure, it is a thing where we can maintain the safe practice on the patient, and it is very important. So that's why these things is important. OSCE-based peripheral IV cannulation. That's why INC also has given too much emphasis in every procedure in our courses, that we teachers should focus on that OSCE-based procedures in every procedure, every clinical situations before sending students to our clinical field. So why we will focus on that? Because it has some advantage. It reduces first attempt failure. Whatever Dolly Madam was told, that nowadays we just do IV cannula just in one prick. So before that, for doing that, actually we need to do simulation based practice. This simulation based practice improve confidence of new learner beginners. It prevents complication, and for all new learner, it helps to maintain a technique as a standardized protocol. It allows safe error collection. So these pathway we want to try to give learning to our students and new beginner nurses also just join in the hospital. We are telling them that you just observe first, then try to do practice, then get feedback where we are doing error, where we can do correction. And you should do repeat until competency is achieved. This is the cycle. Observe, practice, get feedback, repeat until competency is achieved. These cycles we need to maintain these simulation-based procedures. So here I have written some learning objective that first identify correct preparation steps, select appropriate vein and cannula size, observe aseptic no touch technique. We need to do analyze insertion technique and flashback handling, identify common errors causing failed cannulation and apply infection prevention principles in critical care. In this video, we will trying to see these things. But before that, this model I want to show you, this is the model of simulation based scenario. So what this model is telling, first we need to do briefing, why and how. Why these situations we are trying to do as a simulation based, that objective we need to clear to the students and beginning nurses, the new nurses. Then after that we need to give simulation, means demonstration. Skilled जो nurse होगा or teacher need to do demonstration in front of the learners. After that debriefing sessions will be there, question answer session will be there, and after that analysis will be there, error analysis and then reactions. So basically briefing, simulation means actual demonstration of the procedures, then debriefing, reactions, analysis and summary. So by this way we can do the simulation procedure. So before starting the video, so in this simulation, what actually we do, we make a case scenario of the patient. So here in the colleges, nursing college and schools, where here patient is not there. So in dummy we are doing, or in the new lab settings we can also do. So what we do, actually case we need to formulate. So here I have written one case, Mr. Rajesh Kumar, 58 years, sepsis with dehydration. He is in ICU. Condition is weak peripheral veins, mildly hypotensive. So this case scenario teachers has to prepare. After that clinical situation क्या है यहाँ पे? The patients require urgent IV access for fluid resuscitation and antibiotics. So IV cannulization need to be done. Challenges क्या है यहाँ पे? According to the case scenario of the patient, veins are not clearly visible. Patient is anxious. Previous attempt failed and risk of infection is high. Task for student. As a nurse, perform IV cannulation using OSCE steps, ensuring safety and aseptic technique. So here, what we have to do after formulation of the case, we need to do role assignment. So in the lab, different persons will be there to make actual case like hospitals or clinical settings. So here, what we have to do, patient is in ICU and difficult to get the clear vein. So senior nurse will be there, one person whom we will give assignment as a senior nurse, junior nurses will be there, and student nurses will be there. So three nurses will be there, and the three nurses assignment, role assignment, we have to give three persons. One person को senior nurse assign करेंगे, one person को junior nurse assign करेंगे, and third person को senior nurse assign करेंगे. So accordingly lab में हम लोग एक situation को create करेंगे, and after that simulation we need to give to the in front of the learners. So this is the then we will show the video, but before showing the video I want to tell something. Whenever video will be played, these things you need to keep in mind. That is the preparation. Number one is the preparation, and number was second thing, you keep see focus on the site selection and asepsis. Third one, you see the cannulation skill. तो preparation video में जब देखेंगे patient के साथ जब nurse बात कर रहे, you just observe hand hygiene, equipment and patient communication, how she is communicating with the patient. इसके बाद जब साइट सिलेक्ट कर रहे, कौन सा वेन चॉइस कर रहे, साइट का रिस्क क्या है, एंड व्हाट हाउ शी इज मेंटेनिंग द aseptic टेक्निक. Then cannulization, after that you just keep your eyes on insertion angle and how much angle she is maintaining during inserting of cannula. Flashback you see, and catheter advancement you see. Next you see the these things. सिक्योरिंग एंड फ्लैशिंग, उसके बाद आपको देखना फ्लैशिंग करने के लिए, जब जब सिक्योर किया, कैसे फ्लैश कर रहे, कैसे सिक्योर कर रहे, कैसे समझ में आ रहे, जे कैथेटर ठीक जाएगा में है, कैथेटर इज इन इट्स ओन पोजीशन, एंड आफ्टर दैट, आफ्टर प्रोसीड्यूर, what nurses is doing. So I have written this 5 point, whatever where you have to keep your eyes during the video. So now that simulation is started. Now I am showing the video what Hideshwari has prepared in her hospitals, that you just see and you just focus on that.
Oh, the sound is not coming
Sound
in
is
here.
not
So
coming, right?
do you want us to share it? If Shita can share it, she has the video.
Yes, yes, he has. Yes, yes, yes. Please share
You
it.
may need to unshare from your screen, and she can share it from her side then. आप स्क्रीन को अनशेयर कर लो.
Stop sharing. No?
Stop sharing. We're still seeing your screen only. Ipshita, you can try sharing from your side. I guess it can come up then. Yeah.
You can share now, I think.
If the sound include karna, it's the sound is not included, I guess. When you're sharing, no, include the computer sound from the top. You can unshare and
Unmute
then
also. Unmute.
no, that is hers only. Her screen only.
Yeah, give me just 1 minute. I'll just.
हाँ हाँ हाँ, computer sound ऊपर से activate कर देना. It will come.
Good morning, Mr. Mohan. My name is Hideshwari. Today I will insert an IV cannula for your IV therapy treatment. Is it okay? This is IV cannulation tray. This is a different size of IV cannula. This is IV connector. This is pre-filled normal saline with for flushing, and this is alcohol swab for preparation, skin preparation for IV side, and this is tourniquet for easy visible of vein, and this is tegaderm for fixing, and this is sterile SMS sheet for sterile field maintain, and this is Macintosh prevent soil, and this is pair of gloves we use, and this is hand sanitizer for hand rub, and this is skin preparation 2.5% chlorhexidine gluconate for skin preparation, and this is IV tray, injection tray, and this is puncture proof container. Clean the IV cannula site with 2.5% chlorhexidine gluconate. Ensure vein, then maintain aseptic technique. Put the IV cannulation. We will select 22 gauze of IV cannula.
Sound is not coming again. Ipshita, your microphone is muted.
Nini ma'am, there is no sound at that time in the video. Just mentioning in there.
Can I share my screen also now?
Yeah, you can share now.
Okay. Okay. So now, video. One more, just in lab, one more video I want to see. What happened? My microphone is not muted and still it is not.
You are audible. You're audible.
I'm audible, right? I am connected
Yeah,
to my phone.
we can hear you completely,
Okay.
but the video quality is little bit disrupted. It's not clear.
Okay, fine. So one video we have shown. I actually in this lab scenario I wanted to prepare one video. So in lab scenario is little bit difficult rather than the clinical, where actually some problem we face whenever we are try to showing the. My voice is clearly audible or it's echoing? Is it audible?
Yes, audible.
Okay, okay, okay. So actually in lab, what happened? There is no dummy was there. So we are not able to communicate with the patient. जैसे clinical में होता है actually नहीं कर पाते. So that's why in OSCE based, some things are there where we need to keep focus on. That what I told in the beginning, we need to prepare one case scenario in our lab, and every persons we need to keep there for doing role play. So as I told that person is in case of sepsis and he is admitted there in the ICU and it's very difficult to finding out the pain. So one person will keep as a senior nurse, one person's junior nurse, one person student nurse, and they will do just role play. And here how will show here in this video something are not there that we will do here in the error analysis. So that I am not telling what is missing in their video. Now, audience, I will ask the question to the audience. What is the next session in the OSCE procedure? So in OSCE procedure, first is the case, prepare the case scenario. Second is the making everyone to give each role and tell them that what role they will play. And third step is the to demonstrate the procedure actually. जो वीडियो में हम लोग दिखाया सिमुलेशन. नेक्स्ट इज द पोस्ट वीडियो डीब्रीफ क्वेश्चंस. तो ये वीडियो में समथिंग वाज देयर व्हिच वाज नॉट क्लियरली शोन. तो ये वीडियो देख के आप लोगों को क्या लगा जे in this video where was that error, how we could improve in our real life practice or many more. कहाँ पे था जो हम लोगों का प्रैक्टिस का थोड़ा इम्प्रूव करना चाहिए और क्लियरली नहीं दिखाया वीडियो में. ये ऑडियंस के पास मेरा क्वेश्चन है. यहाँ पे कुछ है क्या जो ये वीडियो में नहीं दिखाया. whatever Hiteshwari has done just 4 minutes as I told her that for time limit, but something was missed in this video. What thing was missed? In this video, proper communication was done with the patients before starting the IV cannulizations. She greetings the patients, she took consent from the patients, but वो था क्या something we have done intentionally, something she has done intentionally, because one of the steps is the post video debrief question. This is the process of simulation, that something intentionally she didn't do and she didn't give voice in that video. तो यहाँ पे क्या मिस था, वो किया था क्या कम्युनिकेट पेशेंट के साथ जब वो बोल रहा था जो हाउ फील कर रहे थ्रू आउट द प्रोसीड्योर. जो अभी आप एक प्री सेंसेशन का तरफ फील कर सकते हैं. यू टेक डीप ब्रीथ थ्रू आउट दैट प्रोसीड्योर जो कम्युनिकेट करते हैं हम लोग पेशेंट के साथ. ये था क्या वीडियो में. This session is really interactive. I need answer from the audience. Was there these things in this video? I think it's not there. See, it's not there because she is not doing good at. It's not like that. She intentionally did something so that this slide we can do clearly explain. For that's why something error we have done in this here. So it was not there, right? और क्या होना था ये वीडियो में? और जो होना था.
Supriya, just 1 second. I'll take 1 second. I think she has not done it intentionally. She has done it first time. Maybe next time she'll do it in a better way.
No, ma'am. It's fine. That's what I'm telling. I told her, no problem. I saw the video. No problem. This is the process actually simulation. That something we'll do and we'll ask the question to the students. कि ये कहाँ था और कहाँ हम लोग improve कर सकते हैं. This is the process only in the simulation.
So Supriya, the audience doesn't have the audio here in the webinar. So they have mentioned in the chat box, we have got from Shinoj that the indications are not explained, hand washing is not done. And one more is there from Mulayam saying the wrong biomedical segregation. These three observations are there in the chat box.
Good. That is the actually process in simulation. This is not the fault of Hiteshwari or mine, because we plan to do it accordingly, because this is the one of the process in simulation, that after showing the demonstration, we will ask the audience that what are the steps where we can improve that. Because before that we need to keep that checklist. The checklist एक बार students or audience पढ़ेंगे. After that we will just tell them the what happens if tourniquet is not released. And if flashing, Hiteshwari has given that flashing very well. The flashing वो बहुत सुंदर कर रहा था and it was going very smoothly. Now I can ask my students कि अगर flashing नहीं करेंगे तो क्यों, क्या प्रॉब्लम हो सकते हैं? Why is flashing important after insertion? वो किया था, क्यों किया था? क्यों कैथेटर का पोजीशन देखने के लिए किया था? अगर नहीं किया तो क्या प्रॉब्लम हो सकते हैं? Sometimes catheter can be displaced and we will not able to understand that thing. ये प्रॉब्लम हो सकते हैं. एंड और क्या हो सकते हैं? Hiteshwari has done very nicely that one piece he has done the catheterization. It is excellent. In real situation sometimes it's not happen. For dummy it is happen, but for real situation sometimes it's become difficult. But she has done it very nicely, that thing. But sometimes if you failed it, one time fail हो गया, two times fail हो गया, how many times you will attempt for that? कितना टाइम ले सकते हैं हम लोग हितेश्वरी? अगर एक बार पिक किया हम लोग नहीं हुआ, दो बार पिक किया नहीं हुआ, ठीक थर्ड टाइम पिक करेंगे क्या हम लोग?
No ma'am, only 2 times prick, then
Only 2 times,
call
right?
for help.
Yes, only 2 times. So after 2 times is the maximum. After that, we should not pick. So for the students, they should know that maximum 2 times they can attempt. Otherwise, they will. So in this case, जो case में scenario यहाँ पे दिया, he is the sepsis case and he is admitted in the ICU. 58 years old patient, very difficult to get vein. तो senior nurse का role क्या होगा यहाँ पे? Senior nurse will identify the vein. जो आप यहाँ पे कर सकते, ये वेन सिलेक्ट कर सकते. And what senior nurse will tell? Senior nurse will tell to the staff nurse that you will take maximum 2 attempts. If after 2 attempts it will not happen, we can escalate it to central line catheter. So that will be role of the senior nurses here. But here जो nurse था, she was excellent. She has done in one peak time and it is great. So that is the session of post video debrief question. After video, what error was there? जब डामी में करते तब हम लोग स्टूडेंट्स को ऐसा पूछते हैं यहाँ पे क्या मिस्टेक था, कैसे उसको सॉल्व कर सकते, एंड व्हाट आर द क्वेश्चंस आर कमिंग इन योर माइंड. एंड जो मैं वीडियो स्टार्ट करने के पहले मैं जो 5 पॉइंट्स दिखाया था, जो प्रिपरेशन, ग्रीटिंग्स ऑफ द पेशेंट, साइट सिलेक्शन, क्लासिंग्स, डॉक्यूमेंटेशंस, एंड वहां पे जो प्रोसेस था उसके बाद वीडियो को लर्नर ऑब्जर्व किया. देन इन पोस्ट ब्रीफ वीडियो डिब्रीफ क्वेश्चन में आई विल आस्क दैट ऑडियंस दैट व्हाट इज द मोस्ट कॉमन बिगिनर मिस्टेक, क्या हो सकता है, एंड व्हाट शुड यू स्टॉप फर्दर अटेम्प्ट, जो यहाँ पे हम लोग एक्सप्लेन नहीं कर पाया ड्यू टू कॉन्स्टेंट ऑफ द टाइम एंड दैट थिंग. जो 4 मिनट का वीडियो था, क्यों जब इंसर्ट करेंगे, जब इंसर्शन कर रहा था, then we should tell to our students that if we not maintain that degree angle, 15 to 30 degree angle, that can be the most common mistake for the beginner, what students usually do. And one thing we also don't able to mention in our voice record, that whenever we are pushing the catheter, that time we need to maintain pull and push technique. We are pushing the catheter inside and same time we are pulling our needle, right? But at the same time, suddenly we are not removing our needle, but slowly we are removing our needle. In video we are not able to show that process slowly because it was merging we need to do, so that's why we didn't able to show. So that's there the beginner do mistakes mostly, that we are not able to attempt that process. So this is the post video debrief question. Means after showing the video to the students or learner, we need to ask that where the error are there and how we can improve, and until you are achieving your competency up to the end, you need to practice that point only. So this is the post video debrief question. It is the one of the process of the debrief. Again, I am telling, we are not telling that that video is not proper. Video is exactly proper, and we were pre-planned that something we will discuss, something we will not discuss, because one of the process of simulation is the post video debrief questions, right? I think I am clear to all of you. So this is the checklist of the OSCE. This is the checklist of the OSCE. So what we have to do, this checklist we need to give to the learner. So here again, I have just some points I have written here: greet patient, hand hygiene, collect equipment, clean site with the antiseptic, no touch technique, observe blood flashback, and secure with the sterile tape, document the procedure. So these checklists we need to give to the learner in before. So before we will give the checklist, they will read, then they will show the process. Then after that, the debriefing questions we will ask the audience that why that error was there and how we can improve. And until they will not able to competency in that step, we will stick that one. That आपको यहाँ पे improve करना है, उसके बाद आगे का procedure करेंगे हम लोग. And this is the error analysis. Something I have written here. The touching site after antiseptic. इन्फेक्शन रिस्क हो सकते हैं, जैसे वो दिखा रहा था क्लोरहेक्सिडिन से वो क्लीन कर रहा था साइट्स को. आफ्टर दैट इन बिगिनिंग speaker also they were told that after cleaning the site we need to give time for proper drying. If complete dry was not there, then antiseptic solution will not do proper action. So here most students do the mistake. No hand anchoring, here they do the mistake. Threading immediately after flashback and no flash confirmation, just insert कर दिया, कैप लगा दिया, उसके बाद उसको फिक्स कर देता है. तो नो फ्लैशिंग दे यूजुअली डोंट डू. तो यहाँ पे एरर आ सकता है. तो whenever we will show the procedure to our new learners by simulation, after showing the procedure and debriefing, we need to tell them that these are the common error it can happen and how you can improve that error. So Hideshwari, these cases we have planned to show and we will plan to discuss there. Now you tell me, जो केस में दिखा रहे, ऐसा टाइप ऑफ केस में आप आईसीयू में कुछ प्रॉब्लम फेस करते हैं क्या आईवी कैनुलाइजेशन करने का टाइम में?
यस मैम.
व्हाट प्रॉब्लम जनरली वी कैन फेस?
सबसे फर्स्टली अगर किसी पेशेंट को एडिमा है तो उस टाइम पे हमें डीप वेन ढूंढना पड़ता है और इसलिए हम एक्सेस नहीं कर पाते हैं. कोई पेशेंट को अगर इन्फेक्शन है, स्किन इन्फेक्शन, तो उस टाइम पे हम कैनुला करने में नहीं कर पाएंगे, क्योंकि जहाँ पे इन्फेक्शन है वहां पे हम प्रिक नहीं करते हैं. समटाइम्स अगर किसी पेशेंट को फ्लेबाइटिस हो रखा है, फ्लेबाइटिस या इनफिल्ट्रेशन हुआ है या एक्स्ट्राविसेशन हुआ है, उस टाइम पे हम नहीं कर पाते.
So this problem can happen. So whenever we'll show the procedure in simulation based, the troublesome area also we need to tell the students. जो हितश्री actual clinical situation में जो होता है वो just उनका experience share किया. जो sometimes difficult when हो सकता है. This patient was shock patient जो case scenario में create किया था. Sometimes edema हो सकता है, infiltration हो सकते हैं. So for that reason team is needed. That's why sometimes हो सकते हैं for junior nurses they are not getting vein properly. जो skilled nurses है उसको जरूरी तो होता है. So sometimes that team was needed for that reason. So these are the troubleshooting area in the critical care that we should keep in mind whenever we will do the procedure in the ICU setting. So this is about the OSCE based process. So again, just 1 minute summarization. Whenever we are trying to show the procedure in demonstration in lab or in clinical setting for the new beginner, just we are trying to follow one model. That first we are saying them that how and why this situation or this procedure we will show the demonstration to you. Then उसके बाद हम लोग एक actual checklist देते हैं, उसके बाद simulation देते हैं उन लोगों को. Simulation means demonstration जो वीडियो में दिखाया हम लोग. After that debriefing session होता है. Debriefing session means question answer session. We'll keep क्वेश्चंस टू आवर ऑडियंस, दे विल गिव आंसर, एंड वहाँ पे हम लोग जस्ट आइडेंटिफाई करेंगे जो कहाँ मिस्टेक हुआ था, वहाँ पे कैसे हम लोग इम्प्रूव करेंगे। जब तक ना कॉम्पिटेंसी फुलफिल होगा, जब तक ना जो एग्जामिनर है, जो पढ़ रहे है, जो टीचर है, उसको लग रहा है ना दैट लर्नर अचीव द फुल कॉम्पिटेंसी, जो हम लोग एक्चुअली प्लान किया था, जो समथिंग वी ओवरलुक, that is our plan, pre-planned actually, and that was the debriefing session. And after that, error analysis will be done. So according to error, competency will be developed, and after that, reactions means again that students or that new learner will give the feedback जब तक ना competency fulfill हो रहा है. So that is the actually OSCE based simulation procedures, and that is really very much needed for this IV cannulization, which actually we actually felt for our students. And if we don't show them in the lab, and if we don't tell them to practice until or unless you are failing competency, what they do, they just go to the hospitals, just seeing the one patients kaise IV cannulization kar rahe, and just they're doing 2 prick 3 prick until they are just doing experiment to the patients. So many problems are going on practically. So for that this simulation based teaching is very much needed. So this is all about the thing. Now students who are there, they can give feedback by scanning this QR code. So they can tell something in this questionnaire, something was there, you just give your feedback so that we can understand that whatever point we want to give emphasis or focus, so that you can understand or not, right? So thank you.
Thank you.
Thank you so much, Dr. Supriya ma'am and Hiteshwari, for this session. Your emphasis on stimulation and OSCE-based demonstration remind us that competence is not built in theory, but in repeated safe practices and continued practices. You have shown us that every successful IV insertion lines, long before the patient encounter, it begins in preparation, precision, and practice. In nursing, especially in critical care, our skills are directly linked to patient safety. A well-performed peripheral cannula is not just a procedure, it is a lifeline. To all my colleagues here, let us not rush to perform, let us first strive to perfect. Let us use simulation not as a formality, but as an opportunity to learn without fear, correct without blame, and grow with confidence. Because when we master the skill, we don't just insert a line, we build trust, reduce complications, and save lives. Thank you once again. So
Thank you.
moving ahead, we have opened the forum to the speakers. So in the chat box, there is one question. This question is for Dr. Rahul sir. Are you available, sir? Yeah. What is the main difference between CLAPSI and CRBSI?
Very good.
Basically, the CLAPSI is a surveillance term. Like you can define it as a bloodstream infection. A patient who is having within 48 hours of this central line is there, and there should not be any other infection, other site of infection. But in CLAPSI, when we say we cannot just confirm this thing whether it is because of central line only. So anyone who is having bloodstream infection within 48 hours of the central line in place, we termed it as a central line associated bloodstream infection, CLAPSI. And catheter related is more accurate term when there is no other source, any means by. And the catheter is primarily the source of this bloodstream infection. Then we use this term catheter related bloodstream infection. So CRBSI is more accurately describe this association of this catheter, while CLAPSI is the bloodstream infection when the presence of central line is there, but we cannot 100% say that this is not because of some other that infection is the source from other place of. So that is why there is a more accurate term used PRBSI and CLAPSI as a surveillance system to all the patient who is in the central line having and BSI is there. This is what the difference actually.
Okay. Thank you, sir. Any other questions for speaker? I think there is no questions. So let us move ahead. So I will invite Miss Lini ma'am, co-chair INS India from Madhya Pradesh chapter. She is nursing superintendent care CHL Hospital Indore. I invite ma'am for the vote of thanks.
Hello, good afternoon all. Am I audible?
Yes, you are audible. Yes.
Yeah. Respected INS dignitaries, esteemed speakers, and dear participants, on behalf of the INS India, Madhya Pradesh, and Chhattisgarh chapters, it is my privilege to propose the vote of thanks for today's enriching session. When lines become lifelines, ensuring IV safety in critical care. It's a wonderful heading, as all you enjoyed, I hope so. We extended our heartfelt gratitude to all our distinguished speakers, Dr. Sabha Javed, Dr. Rahul Pratap Prajapati, Ms. Princey Libby, Dr. Supriya Mandal, and Ms. Hideshwari, who generously shared their expertise and insights. Your valuable contributions have deepened our understanding of IV safety, infection preventions, and involving practices in infusion therapy. Each session, from setting the vision and laying the foundation to discussing zero infection goals, clepsy preventions, and simulation-based learning, has been truly enlightening and impactful. I sincerely thank our leadership team, Binu ma'am and Madhugari ma'am especially, for your guidance and vision, which continue to inspire and strengthen our professional community. A special note of appreciation goes to our moderator, Shakuntala ma'am, and organizers who worked tirelessly behind the scenes to ensure the smooth executions of this program. We are also grateful to our audience for your active participations and engagement during the open forum. Your curiosity and commitment to learning are what drive initiatives like IV Talks forward. And lastly, I would like to acknowledge and thank Ms. Pooja Polymed for powering these initiatives and supporting the advancement of infusion nursing practices. As I conclude, let us carry forward the knowledge gained today into our daily practice, ensuring safer patient care and better outcomes. Thank you all once again for being a part of this meaningful session. Thank you.
Thank you, Lini ma'am. And special thanks to the Polymed team, Pooja, Vandana, and Bharti, and also our Chhattisgarh chapter officials for the support of the first IV talk from the Chhattisgarh. And thank you, INS, for giving us the platform.
Excuse me, I missed 3% also, sorry. And then this Miss Dolly ma'am, chair Kolkata chapter, and then Miss Shakuntala Khatam, already the moderator and co-chair Chhattisgarh, and Dr. Vinci, it's MB chapter. I missed three. Sorry, I'm really sorry for that. And even Vandana and the rest of the Polymer team as well.
Okay, thank you, ma'am. Over to you, Pooja.
Thank you so much, ma'am. It's been a long session, but indeed a very informative one. We are getting a lot of positive feedbacks already are there. and a lot of encouraging feedbacks also I will be sharing with all of you. Very much thank you to all the CG and MP officials who are a part of the session, and all the speakers, Sakuntala ma'am, Chabi ma'am, Lini ma'am, and Vinci ma'am. And of course, before we close, I would like to, just introduce to the Ivy Talks team also, Miss Ipshita and Shinoj. They are working behind entirely since the last 2 years with Ivy Talks. Of course, Vandana and Bharti are there from my team, and the backend team, Mr. Lokesh, is there, who enabled today's session, which we lost the track. But then, thank you so much. The next session would be held in the month of May. As usually, that would be hosted by Bengal chapter, East chapter, and Northeast chapter jointly. Along with this, we are also looking forward for the webinar with Colonel Binu on healthcare communication, as ma'am has just introduced to us. So May is really a nurses month, and it is going to be really happening. Looking forward to have all of you on board in the next Ivy Talks. Stay tuned. Thank you. Thank you so much.
Thank you, everyone.
Thank you.